Good afternoon, everybody. This is Ken here from ADHD Ireland. Just to let you know, we'll be going in about 60 seconds or so. Just open the digital front door there. Just waiting for everybody to come in, sit down, have a cup of coffee, and once you're ready, we'll all be good to go. Okay, so we get going. Everybody ready? So good evening, everybody. You're very welcome to our neurodiversity webinar this evening. We're delighted to welcome Dr. Ginny Russell. Ginny is an interdisciplinary senior lecturer in critical diagnostic studies, and she co-leads the genus health and illness team at University of Exeter. She has used psychiatric epidemiology, secondary data analysis, and quantitative methods to examine causes, outcomes, and trends and effects of diagnosis, and her talk will feature some of this work. Her research interests compromise diagnosis, COVID, autism, ADHD, and dyslexia, along with the social biological nexus of diagnostic classification and narratives and health equalities. And we know Jenny is going to talk on those this evening. And the title of our talk this evening is Lumping or Splitting. Should neurodevelopmental diagnosis categories be widened or narrowed? And again, someone comes from the ADHD perspective. I'm actually really looking forward to this because I expect this to be an exceptionally interesting talk. So with that, I'll step out of the way and hand over to you, Ginny.
Thanks so much, Ken. And I hope I can live up to that billing. And welcome everybody to my son's bedroom. He's just gone to Cardiff University for his first term there, studying maths. And as you, so that a very eagle-eyed among you may notice he's an anime fan. So if you think these posters are mine, then they're not. They're his. So yeah. So I'm gonna share my slides. I've got a few slides tonight. So hopefully you can see those now. Yep. Give me a nod.
Yep.
Yep. You got them. Okay. So I'm basically going to just talk about the concepts that I've got in the titles, but I noticed that my own title was rather conflated, so I just want to sort of straighten that out a little bit first, and then talk you through some work that we've done, some research work, which is very much more within my comfort zone, and I'm hoping that will lead to a really much broader discussion within the room around the ideas of lumping and splitting, and also broadening and narrowing. Which are two different things, I realise, after having written the title. So lumping or splitting. So what we're talking about here is the lumping of more than one diagnostic category into a larger category. And some of you will know Chris Gilberg in 2010 wrote a paper that advocated for this, and he's not the only person who's advocated for it, called Essence. I might have got that acronym slightly wrong, but basically the argument is generally around co-occurrence, and especially co-occurring neurodevelopmental traits. And almost everybody agrees there's no such thing as pure ADHD or pure autism or pure dyslexia. Most people who get given these different diagnostic labels have a combination of traits that might represent, different parts of the neurodevelopmental spectrum of traits. So do we therefore need a category around neurodivergent people, so to make it, autism, ADHD, Tourette's, and all of those kind of neurodevelopmental differences into a bigger kind of broader category? And this is what Gilberg was arguing for. Or should we be splitting categories? Because many other people have argued that individual diagnoses are too heterogeneous and they're too catch-all. And particularly autism, there's a big debate about how that should be split into subgroups and subcategories. And obviously doing either of these things has ramifications for clinical identification. but also in terms of intervention and what interventions are recommended, and people's identity as well. So I'm hoping that the conversation will encompass all of those things. But lumping or splitting is not the same as broadening and narrowing. So another problem that I noticed with my title was the word should, which is quite a kind of moralistic word. Should we be doing this? Should we be doing that? But I don't think those sorts of should questions are that easy to answer. I actually think we need to think about narrowing or broadening, or what lumping and splitting might do. What would be the effect of doing that? Would it be have an effect on the categories themselves and how people understand those categories, but also what effect would it have on the people who are in those categories, who receive those diagnoses? So broadening and narrowing, really, we're thinking about the idea of any diagnostic category. If you think about it as a bucket with kind of borders or boundaries around it, broadening would mean expanding that category to include more people and making it more diverse. And narrowing would mean making it more specific, so kind of making the category smaller. And over the years, autism has been broadened quite a bit, and I'm going to talk about that with reference to some research that we did recently, just as an example. So hopefully we can also talk about ADHD, Ken, after that. So me and my colleagues recently published a paper, and I'm going to talk you through our results and findings. And this was a paper about autism, actually, and we looked at GP records going back 20 years in England from 1998 to 2018, and that covered about 9 million patients in England. And what we did was look at the proportion of patients who received an autism diagnosis in each year. So we were looking at new diagnoses each year, not people that already had one, but who received a new diagnosis within the context of that year, according to these GP records. And when we talk about autism, we just use the word autism, and obviously terminology is, contested and different in different contexts. So we included all diagnostic codes that are on the spectrum in that, including Asperger's, infantile autism, childhood autism, pervasive developmental disorder, amongst others. And what we did was break down the trends by subgroup. So we looked at gender and age group and also autism severity. And I'm just going to talk through the results. So what we found overall was this exponential increase in the recording of the diagnosis over the time frame that we looked at. And there are several factors contributing to this. So just bear in mind that we've got the baseline here held at 100%, and this is the index statistic, which looks at the percentage increase over time. But these are incident diagnoses. So these are like the increase in new diagnosis. It's not just the number of people with autism, because that would measure people that had a previous diagnosis. It's the new diagnosis in each year. And you can see the diagnosis is increasingly used. And so there are several factors that are contributing to this. Firstly, we're seeing a rise in recognition of autism clearly, and this is a change in diagnostic practice. So it's a broadening. It's not an increase in proportion of people that have autism per se. And that's partly because the criteria for diagnosis have changed over time. And that's obviously because of the inclusion of Asperger's in the 1990s.
Recording in progress.
Yeah, but also due to increased awareness, obviously, thanks to the work of autism charities and the neurodiversity movement itself. And of course, all sorts of cultural factors like autistic autobiography and well-known adults, well-known figures like Chris Packham and Greta Thunberg. So many adults identifying with autism and indeed proud to be autistic. But also what we've seen in other studies is that as time has passed, less severe autism traits are required in order for a diagnosis to be assigned. So we know autism is a spectrum condition. Indeed, so is ADHD. If you look at this is a graph from our own work again, showing that autism traits, these are measures of autistic traits, that they're vaguely, this is taken in the general population, and they're vaguely normally distributed. Same with ADHD traits and dyslexia traits as well. So if people with less severe traits are receiving a diagnosis, the threshold for diagnosis, which is this line here, is moving to the left. And that's what some studies have shown, that gradually there's kind of diagnostic creep with more people being included in the category. And that's also true for work in ADHD as well. So that was one way of explaining why that we see this sort of exponential trend, because if this is the case, then obviously there are more people near the population mean than there are at the very severely affected end. And another reason, I guess, could be it could be just to do with GPs are better at recording these days than they used to be. And we always have to be careful with those sorts of things in epidemiology, and COVID is a great example of how we need to be very careful around statistics. And also there's been a lot of work around diagnostic substitution, which some of you will know about. Paul Shattuck and other people have written about how autism label is now used, and that's to target, specifically to target resources, particularly in teaching and education, that might not be released if a different diagnosis was given. So there's sort of very pragmatic reasons around giving one diagnosis over another. So just to return to the study again, I wanted to cover this result as well, which was the difference between the diagnostic, the females being given a diagnosis versus males being given a diagnosis over time. And this is in England. And obviously there's no plausible etiological reason why suddenly more females have developed autism as time has passed. So this does indicate that our findings are primarily an effect of increased recognition, not of more people developing autism, not of more females developing autism. So yeah, that we also looked at age bands. And again, what we did was look over time at the new diagnosis of autism. And again, we've got the index statistic here, held at 100% to start with. And you can see the biggest rise here in the green line is amongst adults. So we broke up according to developmental stages, looking at preschool children and primary age children, adolescents and adults that we defined as over 19 years old. So obviously adults were very rarely diagnosed back in 1998 when the time frame starts. And in the UK in 2009, the Autism Act meant that diagnostic assessment centres for adults were mandatory, and local authorities had to provide diagnostic assessments for adults. And obviously these have had an impact on these new incidence figures, because previously adults were rarely diagnosed, and now there's this national apparatus to set it up. So it's kind of like a way of looking at the interaction between sort of social factors and institutional factors, if you like, and how that affects the way that diagnostic practice is done, and the way people understand categories. So all these things to me are quite interrelated. Yeah, I mean, the other area that we looked at was that we also had access to diagnostic subcodes on the spectrum, as I mentioned before, and we categorized Asperger's and atypical autism as broad autism, and infantile autism, childhood autism, and CANAS as severe autism. But most of the diagnoses in this group were just autism or autism spectrum disorder. So there was a minority of diagnoses that were in those categories. And then after 2013, when the DSM-5 was introduced, Asperger's was dropped as a diagnosis, and the GPs were all told to classify everybody as either autism or autism spectrum disorder. And that's why we see this big drop off here. But before that point, what we see is broadly in line with other studies in the US and also in Europe, where there's an increase in what we call broad autism. So people with typical intellectual ability or above average intellectual ability increasing more than those who we classified as having severe autism. So I guess what I'm trying to say here is that the kind of shape of that bucket it's not just that the bucket has expanded, but the shape of the bucket has changed slightly to include different types of people. So what are the implications of this? Well, one issue it raises, I think, is that we can't think of autism, or indeed any medical diagnosis, as a fixed condition waiting to be identified. because the parameters of who had it have changed through time. So I think I've got something on the next slide. Yeah. So Ian Hacking, as some of you will have read his work, I'm sure many of you will have done, has written about humankinds. And these are kind of phenomena that he describes, the kinds of things that are affected by their own classification. So the idea is that these things are in flux, and by recognizing and identifying them, that changes the nature of them. So it kind of undermines the idea of recognition and identify. The words recognition and identification sort of do imply this kind of fixed underlying condition, like a continent waiting to be discovered. But really, this sort of shifts through time and also over space. So in different countries and in different cultural contexts, shift the shoreline of that continent, if you like. That's not to say there isn't landmass there, but the kind of shape of it is shifting all the time. And what counts and who is a citizen of that country changes as well. So to me, terms like underdiagnosis and overdiagnosis are a bit of a red herring in my view, because it kind of depends on where you draw the line or draw the boundary for threshold of who should get a diagnosis and who wouldn't. Where's that clinical threshold? Where's that cutoff? So if we say that 5% of the most seriously affected people with ADHD traits, for example, the top 5% of people with ADHD traits, that's our cutoff, then to say that we're overdiagnosing if we diagnose more than that, or underdiagnosing if we diagnose less than that, seems a bit of a kind of circular thing to me, because we could have defined it in a different place. So yeah, it's in a sense a humankind. And this is a principle that applies to really any diagnosis, certainly neurodevelopmental diagnoses. But of course, it can be quite problematic for those with a strong diagnostic identity who are kind of underpinning the argument for rights with a sort of more biologically orientated arguments. So really, I would say Uta Frith had it nailed, because she was talking about our study, and she said this kind of catch-all quality of autism now makes the diagnosis clinically less valuable for determining care, because there's no one-size-fits-all support or interventions that's right for everybody with autism. And so she's arguing for splitting, to try and be more specific about the different contingents. And other researchers have argued that subtyping should happen along the lines of either genetics, like genetic etiology, or cognitive profile, or along the lines of gender, so the female autism phenotype, for example. And I don't know what people think about that. But also there's this move towards multiple autisms. So again, splitting, so multiple autisms. There's not just one autism, there's lots of different forms of it. And particularly when designing intervention and support. Yeah, and I just wanted to, because this is a talk about neurodiversity, I just wanted to introduce you to this slide as well, which is about really the kind of waves of activism. And this is probably going to be familiar to most of you, but I just really like this slide because it kind of illustrates on a micro level how different factions, and in that I include academics in various disciplinary tribes, have understandings of diagnostic categories that arise and are expressed in resistance to each other, and how in resistance and sort of diffracting off each other, new understandings arise. So the history of autism advocacy and activism and the rise of the neurodiversity movement is one of resistance, where, parent-led movement originally were reacting to the psychiatric establishment and psychiatric establishment expertise to form their own counter discourse about autism in the 1970s, saying, no, we are the experts. And then the neurodiversity movement, which was mainly driven by autistic adults, arose in the 90s in reaction to the quite alarmist and risk discourse that was promoted by some parent-led groups. So no, we are autistic, we are the experts. So what I like about the metaphor of waves is that we have this sort of psychiatric bedrock running through it, but the bedrock itself can be slowly eroded and shifted by the waves, while at the same time it kind of conveys the idea of a bedrock weighing more. In other words, psychiatric ideas are often given more weight and scientific legitimacy than parents or autistic individuals. And of course, the shape of the bedrock influences the shape of the waves. So there's this kind of impression of time and movement and process with each element affecting the other. So I really like that as a kind of metaphoric illustration. Yeah, so I'm going to stop there, but I haven't got an answer to whether we should be lumping or splitting, but I certainly think that it's something that we should be thinking about. So if I can figure out how to stop sharing, I'll just say thank you very much for listening.
Ginny, it's Fiona McNicholas here, and sincere apologies. I was late to start the neurodiversity launch, and I've emailed Ken and Beth privately. I'm dealing with a crisis not only of IT and computers not working. I'm talking to you from my mobile phone, which is very difficult. But I also had a clinical issue and I might have to depart. But I apologize sincerely for that. What I was listening to, and I missed the first couple of slides that you presented, I loved that idea of the continent and the landmass being there, but it just shifting based on, I suppose, where the spotlight is. And I guess one of the things that I wondered if you'd comment about is who is best placed to shine that spotlight, if you will, because you did mention then subsequently the difference between parent-led groups, the neurodiversity movement by the individuals themselves, and then you have clinicians such as yourself providing services for individuals that have identified a specific need.
Yeah, thanks, Fiona. And I'm sorry to hear about your troubles. That sounds really difficult. But your mobile is giving us a good view of you, so that's good. Are you holding it? Are you?
I am, unfortunately, which means multitasking is increasingly problematic. But yeah.
Well, you're holding it together there. Well done.
Thanks.
Yeah. So I mean, I don't. The way that I see it, which is different from the way that other people will see it, of course, everybody has their own sort of situated understandings of these things, but just like any other social health movement defined by identity politics, the autism arenas and neurodiversity arenas can be pretty fraught and contested about who has the right to make claims about, you know, what the particular condition is and who has the right to speak, with different factions claiming authority and each of them pushing slightly different versions of what symptoms or behaviours should delineate diagnosis. So that's true not just for autism and other neurodevelopmental conditions, but lots of other conditions as well. I mean, long COVID is a really good example of where we've seen patient advocacy and people arguing that some sorts of symptoms should be included and long COVID should be defined in certain ways. And that's just emerging now. So I think it's almost like there are different armies behind the different sorts of understandings. And I think that, yeah, a really good example of that was when DSM-5 was introduced, and that was back in 2013. And actually ASAN, who are based in the US, the Autistic Self-Advocacy Movement, lobbied the neurodevelopmental group quite hard for changes that they were interested in seeing in the new diagnostic criteria. So it kind of becomes a political arena as well as a scientific arena. And I don't think you can really separate those two sorts of levels. They get very intertangled. And so who should have the right to speak or who should be included as diagnosable may vary according to particular agendas, experiences and practices. Yeah.
And do you think that it's helpful, because you could say that, well, you know, that there's different spotlights at different times, and in some ways maybe it's the spotlight is the issue that drives most of the controversy or the infighting. For example, if you're the spotlight for service provision, it may be that you choose to shine that on a very different group, than the landmass that might have been shun upon by others. And maybe part of that is driven by the science. There's no point providing a service if there isn't an evidence base there that supports it.
Yeah, absolutely. I mean, I'm all for the evidence base, but I think that what I was trying to say was that science too is driven by political agendas. It's not always just as simple as we look at the evidence, although we should, in a very neutral and objective way. I mean, in Anglophone countries, at least, we have data to see that autism and ADHD and dyslexia are all being diagnosed more often, both in children and adults. And the kind of scientific question is around why is this, and what constitutes these categories? But I think a better question, arguably, is it helpful to diagnose so many more people, and who is it helping, and what effect is it having? And I think that's, in a sense, that we should be thinking about the utility of the diagnosis much more than like the validity of whether the category kind of hangs together, or what's the evidence base behind it and the research. I think that's important, but I think at the end of the day we need to think about who is this helping, and where is it helping them.
I agree very much with you there about whether it helps. And I'm reminded of a large international study I was part of called the Milestone Study. And we did some qualitative interviews with a large number of young people and their parents, over 100. And one of the things that they said is actually they valued a diagnosis, and these were young people who were at the transition boundary between leaving child psychiatry services and moving on to adult services. And so they kind of had that period of being part of parent-led advocacy and then moving towards self-advocacy. And one of the things they felt was it gave them at times an understanding of difficulties or differences that they felt they had compared to others. It also gave them an opportunity to consider treatments that might be available. Whether they wanted to pursue them or not is another thing, because even if you've got high blood pressure and medication will reduce it, you might opt for various reasons to say, actually, no, I'm happy with, a different way of approaching that. So I do very much agree with that, that diagnosis is much more helpful to some people than others. But I guess what people really get saddened by is a diagnosis that's poorly made, that's inappropriate, that's not reviewed, that then defines the person where, they feel that they're only being viewed as an ADHD kid or a OCD young person or whatever.
Yeah, I mean, if I could just comment on that, I totally agree with that. And I think diagnosis is a double-edged sword for people. I mean, diagnostic categories as well have many sort of functions beyond what you might call the clinical model of identifying the issue from a series of symptoms and then treating it. It's also incredibly useful in many other ways, like for clinicians, it helps not to organize treatment, but also it's like it determines the pathway through services, it predicts outcomes, it gives us a common shorthand for a series of symptoms or traits. So it's a way of communication as well, but it also provides a structure for many other areas of life, both economically and socially. So for example, insurance companies, maybe, diagnosis validates accessing payments, etc. And for researchers like us, diagnosis is a way to organize the field. To activists, it's a banner to rally under. And for lawyers, it's a way to decide who's responsible for their actions, like a way to mitigate for actions. And as you say, it's pretty crucial for parents and for children in terms of gaining access to services, but also rewriting biography, like you say, and providing this explanatory frame. But I do think also there is this stigmatizing, and like you say, it's like it can become a lens through which lives are read, like a kind of master narrative. And especially a diagnosis like autism or ADHD can become almost like a way that people see somebody if it's disclosed, and they then read the person through that framework without really thinking about other characteristics they may have or other levels of their personality. So that sounds like that's kind of fairly consistent with what you found in your qualitative study.
And it's something, Ginny, that a lot of the members watching today are chatting in about, kind of agreeing with that. It can be a double-edged sword based on that. Just in terms of the increase in autism amongst girls, you said because there's kind of no plausible reason for that, you kind of think it is a little bit more of a service thing, do you think, where maybe there's more of an awareness of difficulties or differences and that leading people to consider it? Or, do you think that's because, there's a changing gender set anyway amongst male and female in terms of roles and responsibilities, jobs, way of behaving?
I don't think it's the latter. I think my guess, and it's a guess, is, or speculation, let's say, is that it's to do with the fact that there's been quite a well-publicized story around underdiagnosis of girls with autism and with ADHD. And that's been driven by the autism charities and the ADHD charities, and also lots and lots of personal testimony as well from women in particular. So I think that's one of the reasons, and in research literature, that's a huge, it's almost a field in itself now, as you probably know. And I think we wrote a paper back in 2010 about underdiagnosis, or underdiagnosis, as I say, isn't a term that I like because of the, the boundaries issue, but that girls with equivalent traits to boys, this was children we were looking at in the general population, were less likely to receive a diagnosis. And we found the same was true, like in a paper we published last year, for receiving medication for ADHD. So these are sort of social stereotypes, but they have been challenged quite a lot. And the stories, the challenge, the fact that they've been challenged, I think, has made people more aware of it, and has meant that far more women are identifying with these conditions, but that's also to do with the broadening of the condition to include people who are intellectually able in the case of autism, but also the fact that diagnosticians and in multidisciplinary teams are very aware of those issues around gender and neurodevelopmental conditions and possible under recognition. So I think all those things together have combined to lead to this increase that we're seeing in females being diagnosed.
I'm intrigued by what you said about medication use. Were you saying that in females with ADHD, they were less likely to be offered ADHD meds? And if so, what was your kind of take on that?
Yeah, that was a paper we published last year in Social Psychiatry and Psychiatric Epidemiology, or it might have been the year before, actually. Time flies, right?
When you're enjoying yourself.
Yeah. Yeah. So we did a similar sort of thing, or at least our methodology there was that we controlled for ADHD traits. So we looked at everybody with a diagnosis of ADHD in a population-based sample,
right? And
we controlled for severity of ADHD traits. So we were looking at whether girls or boys, or males or females, I think it was, were more likely to receive medication, and males were more likely to be given ADHD medication, even though they had equivalent, levels of ADHD traits. And the reason again, it's speculation, but the reason that we kind of put forwards in that paper were, and that's called, I think, Barriers and Predictors is that paper. I could probably put it in the chat if anyone's interested. It's called Barriers and Predictors of ADHD Medication, I think it is. Was because it's about being disruptive at school. And actually, although the boys, the males, I think it was children we were looking at, I can't quite remember. Yeah, it was children. Basically, we also took a look at the kind of conduct issues and found that, as is quite well known, boys are much more likely to have externalizing behaviors, to act out in disruptive ways, whereas girls tend to internalize their distress around anxiety, depression. They're more likely to suffer from those sorts of mental health difficulties, whereas boys are more likely to be externalizing. And so we equated that kind of level of externalization to being disruptive in schools, therefore more likely to be picked up.
Yes.
Teachers wanted to keep the classroom quiet. So that again kind of raises issues around control, but also under medication. So both sides of the coin, if you like.
Yeah, yeah. Ginny, I'm going to open it up to Ken and Beth, who might put specific questions from the audience to you.
Okay, well done for surviving that on your mobile.
I'll, as long as I can, I'll stay linked. Thank you.
Could I maybe just jump in? The first question there actually came in from Alison, and she was saying, I was diagnosed with Asperger's and ADHD this year. I questioned the use of the term Asperger's as I thought it was no longer being used, but the assessor said she was using a different scale. I do think it's easier to identify as someone who has Asperger's and autism, as I'm high functioning. I think splitting makes more sense to a point, as I feel bad lumping myself in with those with severe autism as they've such a different struggle. And she was saying, can you explain about the two different scales? And can practitioners in Ireland choose between the scales? And is the diagnosis as female Asperger's in 2021 valid? Question mark.
Okay, well, there's quite a few questions in there.
Yes, I think there was 3 or 4.
Yeah, I mean, the first one was around the use of Asperger's, and I use a hard G. I know a lot of people call it Asperger's, but I call it Asperger's because that's what the Germans do, and Asperger was from that area. So yeah, I think it's actually whether you can get that diagnosis now. I mean, I think it's highly problematic that it was dropped from the DSM, firstly because lots of people have an identity and a culture built up around that particular diagnosis, and you can't just suddenly say, oh, the evidence says this, therefore this is now doesn't exist, you know, when there's a huge group of people who are using that and operationalizing that identity, and also using it to form very helpful groups for themselves, etc. And unfortunately, I don't know what the situation is in Ireland, but over here, the situation is that it's a bit of a lottery as to whether you're going to get that diagnosis. It depends what clinic you go to. It depends what clinicians' practice is like, whether they think that's something they want to give or whether they just have dropped it altogether. So it's a very patchy picture. I mean, Fiona, I don't know if you can comment on the situation in Ireland.
I can. I was going to try. I'm distracted. I was going to try and get on the computer, and I can stop holding the phone. I agree. It's very different, and it depends on the training and I suppose the persuasion of the clinician. That's why it's helpful at times when clinicians use some objective measures like the ADOS or the ADI or the DISCO, Norna Wing's examination. My issue there is that actually I do believe clinical diagnosis should be made by clinicians, and that, you know, structured assessments should only complement those, and that sometimes very subtle signs are not obvious in clinical settings where the clinician is generally quite expert and used to getting a young person to engage and get the best out of the interaction, whereas you have to do a school visit. I'm talking about children, obviously, to understand the difficulties that child might have when in a less structured setting by individuals who are less accepting of differences. So I think it's like anything where you are at a very extreme end of a spectrum separating you from the general group, it's easier to see that there's a difference. But when you're much more closer to the edge, it's much more difficult. And that's also where I think within the neurodiversity group, there are some of us who have a diagnosis, a neurodisability diagnosis, whether it's ADHD, ASD, dyspraxia, dyslexia. But given the situation we're in, we may not be so impaired by it that we're quite happy not to receive the diagnosis. Even if somebody was giving it to us, we may choose not to identify ourselves very much in that area. But if somebody's in a different personal setting, even being much closer to the norm of that group may be hugely impairing for them. And again, as a clinician, what I generally feel myself in practice is diagnostic groups are very helpful to understand difficulties, strengths, weaknesses, and as I say, understanding an evidence base of treatment that go with it. But that we should also be considering as well being brave enough or listening to the parent and the child's voice and difficulties enough to think about when we might bend what might have been our own rules or regulations, you know, and that we work with more working diagnosis or working therapeutic engagements with individuals who've come for our help. So it is complex.
Sorry, there was a question here, Ginny, from Becky in the audience, who says, I understand the argument you said you just first made about splitting, but I can't help but think looking for a one-size-fits-all solution, even if you just reduce who all applies to, is what is wrong with our healthcare system. One size will never fit all, and it may actually reduce my access to adequate treatment if you put me in a group that meets my needs less than another group. Do you think that the situation with autism and possible ADHD, the very use of the word spectrum, will lead us to a more holistic approach to viewing developmental disorders? I hope that made sense, Becky says.
Yeah, I think that makes loads of sense. And I really hope you're right. I think that's a really good point. I mean, personally, I would like to see, and this is just because I'm talking from a parent's perspective as well, I would like to see, because both my kids have had challenges, but there've been a kind of range, a mixture of, you know, ADHD traits, autistic traits, dyslexia, all sorts of stuff rolled into one package. I would like this kind of diversity agenda to become more integrated into clinical practice, and less kind of diagnostic silos, if you like, in the way that clinicians work, because I find it very depressing in a way that kind of, because although I can understand how useful diagnoses are as kind of individual diagnoses for clinicians, but they also mean that we tend to get autism services, or, you know, I mean, that's getting a bit better, but the services are sort of divided up around those particular delineations, and that tends to rareify the delineations and siloize people. But yeah, I'm very much on board with the idea of a spectrum of conditions and a spectrum and diversity. If we could think about people as individuals that had a kind of range of different traits, a range of different challenges, a range of different, I know we're kind of post-strengths, I hate to say strengths, because I got attacked recently for saying strengths. So I think we're in a post-strengths world. We could talk about that. Yeah. So yes, I definitely agree with that question and that sentiment.
Yeah, can I maybe just throw more of a political question to you than anything else? Well, you've touched on diagnostics and labels. You know, there is a debate raging out there at the moment, whether it's a person with autism or an autistic person. Where would you come down on that discussion?
Yeah, well, I mean, autistic, I've had that drummed into me because I work with Stephen Capp, who's an autistic activist, for about 5 years, quite closely. And, you know, he's basically taught me that he's an autistic person. That's how he wants to be referred to. And that's how many of his colleagues in the advocacy movement want themselves referred, because they were very heavily influenced by the writings of Jim Sinclair, who was an autistic activist back in the early 90s and who really launched the neurodiversity movement. And one of the writings of Jim Sinclair explained that if you talk about a person with autism, you're describing autism as a kind of disease that can be removed from the person or is curable. Whereas Jim Sinclair said, well, I don't see it like that. I see it as something very integral to myself. It's a bit like saying person with femaleness. You know, it's not a kind of something that I'd care to discard or that I can separate from my intrinsic self. And that's why the neurodiversity movement advocate for the use of the word autistic person, so that it's, you know, it's a part of them as opposed to something that can be separated out. And but then again, if you work in psychiatry, then there was a debate, you know, maybe 20 years ago about that kind of language being stigmatizing. So that's why the language was then changed to person with. in order to not kind of stigmatize people through that, seeing them through that only that one frame. So that I can see the debates on both sides. And I actually have to use those two terms interchangeably because I've written in both sets of literatures, and some journal requirements, as people here will know, require you to say person with autism, whereas others, well, increasingly some require autistic person. For example, autism in adulthood is an example of that. Yeah.
And just to say, in our own neurodiversity seminars, we've had speakers who've actually said the exact opposite to what you've said, that they prefer to be considered a person with autism because they feel otherwise defines them too much, and there's a lot more to them than what might be, you know, assigned to whatever diagnosis or name, you know, that we use, whether it's depression or autism or ADHD.
Yeah, I mean, I think Jim Sinclair's argument around saying person with femaleness is a really powerful one, and a lot of people are kind of coming over to that now. But I use the two terms interchangeably, and I think that's the way to go, you know, not to get too hung up. But that's my own personal opinion on language.
Could I just extend that? And apologies, Ken, you probably have another question. But Ginny, do you think it's something about the transient nature of some issues that within psychiatry, you know, like a depressive illness, you know, is an episode of depression, and sadly for many people it recurs. But there's that expectation of while you have it, no more than while you have your cold or while you have your fever, you know, that you do have a illness, disability, impairment that responds to intervention and then goes. And once it's gone, you have the rest of your personhood there.
Yeah, I mean, I think there's quite an interesting discussion to be had around the difference between neurodevelopmental disorders or conditions, let's say, and mental health conditions. And really it's around conceptualization, because if you start to think about it and pick them apart, then mental health conditions are thought of as more transient, like you say, and they're also not thought of as something that are lifelong. Well, that does mean less transient, doesn't it? More transient. But also neurodevelopmental conditions are sort of more fixed, more stable, more biologically based in terms of genetics and underpinned by those things. But then we know from research that also depression and schizophrenia and all sorts of things that are considered to be mental health issues are also genetic and have genetic predispositions. So when you really dig down deep, it's actually quite difficult to separate out, you know, in discrete way, what is a mental health condition and what might be neurodevelopmental. And again, there are like blurrings around a co-occurrence of different conditions. But I think in terms of advocacy, and maybe this is something I could ask Ken, advocacy and activism, then it's really helpful to separate out neurodevelopmental stuff, neurodevelopmental conditions from mental health conditions, which are seen as a completely different thing and can be treated, you know, successfully and are transient.
Again, that's one of the arguments we have with the HSE, which is our equivalent of the NHS, in that, you know, children in Ireland go through CAMHS, which is the same in the UK, but it's the child and adolescent mental health services. You know, we make the argument that, you know, that you're born with ADHD, you die with ADHD like autism. So therefore, it's not a mental health condition per se. It's the stigma that brings on the mental health conditions. If you remove the stigma, you'd remove the mental health conditions. So we certainly, you know, approve of a position like that.
Did you have another question, Ken, from the audience?
I think Beth's jumping in on that.
Yeah, sorry. Yeah, that's signing back there. Sorry. So maybe we've 5 minutes left, so I might just put in 2 questions together here to finish up with. So there's somebody who's just looking maybe for some kind of further reading that you could recommend, Ginny, around the kind of lumping and splitting concepts. And then a question from Christina, who says, I can see the benefits of splitting, particularly in targeted treatments. Can you explain more of what the cons would be with this approach?
Yeah, in terms of extra readings, I can send those over to you, Beth, afterwards, if that's okay. I can send a list of recommended readings around this particular topic.
Yeah, you can send that on to me. Yeah.
In terms of the cons of splitting, it's almost like Andy Warhol once said, everybody will have their own 15 minutes of fame. Right. And I feel a bit like that about diagnoses. You know, if you look at the Diagnostic and Statistical Manual of Mental Disorders over the history of it, the number of different diagnoses has massively proliferated. And actually, it's almost like the more splitting is done, the more, if you're talking about it from an activist and a neurodiversity point of view, then it's kind of I think a little bit divisive unless we can have that umbrella-y movement that they do maybe with sexual minorities with the rainbow flag. I think there's lots of good arguments for splitting in terms of interventions and treatment and trying to look at what works for different groups of people, because clearly there is no one size fits all treatment for even for people with autism and people with ADHD, let alone for a kind of combined neurodevelopmental diagnosis. But in terms of identity, I think that's a different question. And I think actually for people to have their own individual diagnostic identities is not necessarily that helpful in terms of understanding these kind of conditions as really very blended things. Yeah, I'm not making too much sense there. I mean, what I learned particularly from Jenny Hayes's work, who was one of our PhD students, was that the way that diagnoses are assigned in practice, and she studied multidisciplinary teams in neurodevelopmental clinics who were giving different sorts of diagnosis, was that there was a lot of this kind of bending of the rules. So it didn't matter what ADOS, especially in borderline cases where maybe there were ADHD and autistic traits and aspects of dyslexia or Tourette's or other sorts of challenges that people had, then the way that diagnoses were often assigned was to do with not whether a person had one thing or another thing. It was more to do with how helpful would that particular diagnosis be for that person at that time, and how much did that person want that particular diagnosis. So it's kind of like, I think one of the problems with splitting is it sort of reifies and makes these very kind of niche diagnoses real, whereas actually they're just approximations. It's not like we're carving nature at the joints, even though we'd like to. Yeah, I mean, I'm not saying I don't believe people have impairing and profound neurological differences that bring huge challenges. I do believe that. But around the diagnostic zone in particular, it's almost like sometimes these conditions are revealed and shaped in the telling and the clinical assessment of them and the way that these clinical assessments are done. So it's not that helpful to kind of have lots and lots of different mini diagnoses, in my view. It's a bit like Schrodinger's cat, you don't know whether you have it or not until it's observed, and the observation might affect the outcome.
Maybe just one last question for myself. You mentioned the concept of multiple autism earlier on your, that's reasonably new to me. Could you maybe just explain a little bit more about that?
Yeah, I mean, there's lots of different ways that autism is expressed, as you know, and also lots of different ways in which it's the etiological pathway of autism develops. Sometimes that's very clearly from a genetic difference, and sometimes it's not. Like sometimes it's affected and exacerbated by experiences during early infancy, or during pregnancy of the mother, or even throughout the life course. So I guess the idea of multiple autisms is that there isn't one kind of thing that is autism. There are just lots of different ways to be autistic. And I think that's kind of what, is it Temple Grandin who was talking about when you've met one autistic person, you've met one autistic person. That's a famous quote. I don't know if that was her. But I think that's kind of what the multiple autisms book and concept is getting at. And somebody's written a book on that, actually, which I'll put in the reading list that I send to Beth, if that's going to be helpful.
Thanks very much for that. I really appreciate it.
Great. Well, Ken, very well. You got in the nick of time there. Ginny, thank you so much for your presentation. The videos will be recorded and on the website. I'll certainly go back and listen again when I'm able to concentrate on the beginning of it. And I remember I used to work in the Newcomen Clinic in London, and there was always the question, are we lumpers or splitters? And it was interesting, even amongst a group, which I guess is life. There's always going to be people who have different views on different things for good reason. And the only thing in my book that I want to do is find out somebody who's too rigid for bad reasons. And as somebody said there in the chat as well, ask the person. You know, I think that's so important when we're going along, whatever route we're going along, whether it's providing services, whether it's engaging in services ourselves, whether it's running organizations like universities or job opportunities. Ask individuals how they're doing, and are people being suitably respectful to them, and are there any ways to improve? So you're very much in that space, Ginny. So thank you very much for all your contributions and for the webinar today, and indeed your academic work as well.
Well, thanks. It's been an absolute pleasure to be here tonight.
Lovely.
Thank you.
So an invitation for everybody to join us. Beth, you're probably got it at your fingertips for the next, or I do as well myself. It's the 25th of November, my son's birthday, so I actually won't be able to chair it. So apologies for that, but I know that in advance. Thank you everybody for joining. Have a good weekend and stay safe at this difficult time. Take care.